I sincerely think the most useful part of this is going to be the presentation. Everybody likes to see somebody fumble around live, and it's all do for you. But hopefully I'll be able to unfold it, but you're only going to see one unfolding technique. In the videos you'll see a number of different unfolding techniques, and I want you to keep these in mind when you're in the operating room, and you'll have access to this presentation, so you can review it before you do surgery, and so it's okay, this is how I'm going to get this graft to unfold. That usually gives people the most pause, the most trouble, is trying to get it unfolded and centered. So that's what we're going to focus on in this talk. By way of disclosure, I am a consultant for CorneaGen. So, surgical technique. This, what we're going to talk about is about half of this presentation I give on DMAC, from making the iridotomy preoperatively to the air injection as a last step. So we'll focus on what we're going to look at today, which is really insertion, unfolding, and centration with air injection. So starting with insertion. I use exclusively now preloaded DMAC tissue. I converted probably 1 or 2 years ago when it became clear that it was just quicker to do it this way and avoids the risk of tearing the graft myself. I was getting pre-stripped, but not preloaded, so you still had to do some removal from the stroma, and there was a concern about the risk for tearing. So this is all I use now. So it comes loaded, as you see, in this carrier. You just take out the cartridge, and I do it slightly differently. I do it in a Petri dish. They're showing it above a Petri dish, where you take off the plastic protector on the back end of this goiter cannula, connect a 5 cc syringe, some people use a 3 cc, either 3 or 5 syringe, to the back of the goiter cannula. And then the goiter cannula is filled with Optisol, of course. I think you want to get rid of that Optisol. Some people says it makes it more slippery, more likely for the graft to detach. So it's actually not that hard to just slowly push on the plunger so the Optisol comes out and the BSS replaces it. And if you do it in the Petri dish, you can see the Optisol come out, looks kind of like oil and water. Once it's clear, you know that that graft is ready to go. Sometimes, when it comes to you, the graft will be at the very back end of the goiter cannula, about to come out. So in that case, you're going to, I usually tap it, so I have the goiter cannula. If this is the wide end, and this is the narrow end, I'll actually tap it, so the graft sinks down in the cannula towards the narrow end, away from the wide end, so then I can connect the cannula to the back. If it happens to come out, the graft of the goiter cannula, not a big deal. You're in a Petri dish filled with BSS. You just disconnect it and then you aspirate it back in. I don't know if we have the tubing that comes with the goiter cannula, but I can show you guys that maybe if we have time. It's quite easy to do because you're aspirating it in through the wide end of the goiter cannula. It's fairly simple. So once it's loaded, then you're going to insert. I'm going to show you in the video one thing I think you should do, which is look at the configuration of the graft inside the goiter cannula. Ideally, you're going to have a double scroll. Because if it's a double scroll going in, correctly oriented, you are going to have very little work to do as far as unfolding, and I'll show you a couple of videos. So it does behoove you to take your time looking at how it's configured in that goiter cannula. So, it's a 2.4 millimeter incision. I have an AC maintainer always, because I've used that for the scoring and the stripping, but rarely do I use it during the insertion. So you see there a fairly easy insertion. Your cannula goes in just to the inner portion of the clear corneal incision. Clear corneal incision usually around 1.5 millimeters. Too short, you can get iris prolapse, and you're going to struggle getting that graft in. Too long, and you're going to have trouble getting the graft in the eye enough that it's not going to still be in the tunnel and thus want to come out as you come out with your goiter cannula. So I think about 1.5. If you're doing, yes, please.
Most of the people, they say you need to use a second instrument to, collapse the AC while you are injecting. So you are not doing this.
In that case I didn't, because I could tell that AC was not over deepened. You'll see that in this next video. So thank you for setting me up. Okay, so here's another insertion. Again, AC maintainer is off. Slow, short little bursts of fluid while pushing down on the plunger. Now, take out the AC maintainer. Okay, I want to make sure the chamber's not too deep. So there you go. There's that depression posterior to the paracentesis to burp some fluid out. See how I'm getting the graft to rotate? By doing that, that makes it less likely for the graft to follow me out. So if you can inject a little bit of fluid, get that graft to rotate a little bit, then come out, you're much, much less likely to have a graft expulse through the main incision. Now I mentioned the fact that you would like to, if you can, have the graft in a double scroll or even a single scroll, but correctly oriented going in, because that means it's going to be a quicker unfolding. See, if you cannot see my arrow, so I'm going to turn on my laser pointer. And there we go. All right, so in this configuration where it's overlapping on the top, when you turn the cannula tip to open to the right, if it's correctly oriented, that overlap will go to the right as well, right? And then if you turn it to the left, the opposite. If, however, it's overlapping on the bottom, the graft is upside down, you turn the cannula, the open face of that cannula to the right, then the overlap will go to the left, it goes the opposite. So by rotating it, you can tell how that graft is oriented. Because sometimes it's hard to tell, is it like this or is it like this? But this is an easy way to determine how it is oriented inside of your cannula. So, let's get off the laser pointer here and take a look at, here's a patient obviously with a trabeculectomy. We're doing DMAC routinely in eyes with prior glaucoma surgery. It can be more challenging, of course, as they can be for DSAC, but certainly are candidates for DMAC. So, I'm going to insert the graft here. Again, we're going with the end of that cannula just at the inner portion of the clear corneal incision. And it's going to be short bursts of fluid. That graft's come out. See the double scroll? Double scroll up. So I'm going to be rewarded for orienting that cannula such that the double scroll goes in upwards. Because you can see now, as I'm going to slowly pull out my cannula, little short burst of fluid, now it's starting to unfold for me. Still in the tunnel. Always want to tap the cornea to get it out of the tunnel, first step. But now I'm just tapping in the middle of that graft, and I have a graft that's already unfolded, and I haven't done anything. That's a 5-second unfolding. Why? Because I took the time to make sure it was a double scroll up in the cannula before I inserted it. Really, really can make your life easy. It's not always going to happen that way, but take advantage of it when it can. Again, double scroll. I've turned that cannula such that I know the double scroll is going to be going in up, with scrolls up. Take out the AC maintainer. Again, I'm making sure that chamber is not too pressurized as I'm coming out. I'm just getting a sense for how deep that chamber is. I'm going to tap, what you're asking about. Again, taking a little bit of fluid out that paracentesis. And you can see that graft's already unfolding for me. So all I have to do is tap in the middle. I've got a nice double scroll. I'm going to press and release maneuver. We'll talk about that at the limbus. And again, this graft is already 90% unfolded and I haven't done anything yet. All because I took the time to make sure it's correctly oriented. So, got that point.
Now, if you find it's not correctly oriented, what do you do?
If it's not correctly oriented, let's say I can't get a double scroll. Sometimes it's just a single tight scroll in the cannula, just inject it and then unfold as necessary. The only step of DMAC that's easier than DSAC is flipping an inverted graft. So it's not that big of a deal if you get an inverted graft, but it is awfully nice if it comes in as you want it already. So donor orientation, how do I figure out now if this graft that's inside the eye is correctly oriented or not? Well, nobody does DMAC without staining the graft. So that's universal, number one, got to stain it. Almost everybody, Sophie Deng, my colleague, does not use an orientation mark like an S-stamp, but the rest of us do. So S-stamp, also some people, if I'm doing it sometimes outside the US when the graft's not marked, we will use a Sinskey hook to make these little marks, 1 and then 2, such that if it's correctly oriented and you look at it going clockwise, it's 1 and then 2. So you can make marks like this if you need. Let's say the S-stamp is not there, it's hard to read, you can put marks on, but usually your grafts are going to be marked with some orientation mark. The blue cannula and double line signs. So the blue cannula sign can be very helpful to determine orientation, especially in cases where the view is not good. If your graft is correctly oriented means scrolls are up. You put your cannula in the middle of it and then move it to one side. If it is correctly oriented and your cannula passes beneath the scroll, the tip, as you see, will turn blue, like right here. If, however, that graft is upside down, the scrolls are going down, and you start in the middle and move to the side, your cannula will just pass over it and the tip will never turn blue. So here's a good example of it. Intra-op, you can see very clearly the tip here is blue. Here you can see the tip is blue. That's easy to see. Sometimes the cornea is not as clear as this. So you have to really look carefully sometimes to tell how it's oriented. The downside of this, using this technique, is if you're wrong, and you're touching the graft with your cannula to do this, you're touching endothelium. So I know some surgeons like to do this a lot. I'm a little bit more reluctant because if I'm not right, I'm causing some endothelial damage. If the view through the cornea is good enough, I like to do the look for the double line sign. Takes sort of advantage of the same principle. If it is upside down, there is just a flat surface. You're not going to have a single light reflex off this flat surface. However, if it's oriented correctly like this, light will reflect off the apices of the DMAC graft and give you this sort of linear reflection, as you see here and here. So in this case, there's just a single line kind of off right in the middle of the scroll, but here we can see very clearly that there's two linear reflections. Same thing can be seen here, where we see a linear reflection there, and this linear reflection very easy to see. So look for this. You're not always going to see this because the view may not be good enough. Sometimes the eye is a bit turned, a little torqued, but if you can get the eye in the proper position, like in a case like this, an A, very easy to see this double line sign. So keep that in mind for determining orientation. Other ways to determine orientation include using a light pipe, like Retina uses, held at the limbus, chandelier illumination, can also give you a good idea of what's going on, especially in the case of the very cloudy cornea. Using a slit beam, we have on our microscopes, we have the Zeiss Lumera that has on it a attached slit lamp that can take an optical section with light through the graft and show you exactly how it's oriented. Now that we have intraoperative OCT, we don't use this as much. But if your surgery center doesn't want to pay for intraoperative OCT, you want something to help you determine orientation of graft, this slit beam can be useful.
Is that a Zeiss product or is that?
That's a Zeiss. That's on the Zeiss Lumera 700, an option on that microscope.
And if it doesn't have the option, can you add it?
You can add it. You can add it. Yep. You just add, basically it's like little tracks that you add on the bottom of here and it slides in. It's a nice feature. So now let's take a look at the use of the OCT. Top right, you can see this graft pretty easily is oriented correctly, but you can probably tell through here, looking for things like the double line sign is correctly oriented. Your view's pretty good here, but OCT confirms orientation. However, in this case, brown iris, worse view, hard to tell it's oriented. Look at the bottom right, very easy to tell how that graft's oriented. So intraoperative OCT, very helpful. We have one at Stein where I operate, and anytime I'm doing DMAC, I request the intraoperative OCT. Problem is, colleagues also like it, so some days we have to fight for it. Other thing we use it for is when I have a firm air fill in the eye, both DSEC and DMAC, I use this to look for any sort of interface fluid. I have noticed, interestingly, cases where there is some fluid, even DSEC or DMAC, where the graft remains attached. So I think somebody needs to do a study looking at correlation between intraface fluid and detachment rate. Regardless, I still, when I'm using it, want to make sure I have no interface fluid at the end of the 10-minute air fill. So if you say, shoot, my graft's upside down, how do you get it to flip? Well, what you want to do is create a rotational current in the anterior chamber. And you do that by injecting fluid either above or below the graft. So in this case, we're injecting fluid upwards, which creates this turbulence, gets the graft to spin. You can also inject down at the iris to get that graft to spin. So let me show you here video of a patient in whom the graft is upside down. And it's a little hard for me to tell. I've got a double scroll. One thing is I don't see the double line sign here. Because I didn't see it, I was suspicious this thing could be upside down. So I'm starting to tap it out a little bit, trying to get it to unfold. I see an S stamp here. But at this point I say, oh, it is upside down. So watch that S stamp. Short burst of fluid down at the iris, just flipped it to now it's on that side. Okay, so very small burst. Don't point at the graft. If you point at the graft then goes in the opposite angle. It's not going to flip it. You really want to come in perpendicular to the long axis of the graft, pointing down at the iris, up at the cornea, and create that flip. And it's quite easy to do, especially when it's in that sort of configuration. If it unfolds and it's upside down, and I've been there more times than I like, then you got to get that thing to get into a scroll and then flip it. So that's when you do inject at the graft to try to get it to scroll up and then flip. Okay, so now donor centration and donor unfolding. This is, I think, really the crux of this presentation. Keep in mind that you should have an arsenal of techniques like cataract surgery when we're thinking about how we're going to do nuclear disassembly, same thing here with DMAC. You have external techniques, things you're doing outside the eye to get that graft to unfold and center. And those are tapping, compress and tap, also known as Duracimer to cannula technique, and compress and release, which is my favorite maneuver to get a graft to unfold. Internal techniques involve injection of fluid. You'll see 1 or 2 videos here where I'm injecting fluid at a graft, usually it's when it's in a scroll, to try to get it to unscroll. Fluid release. When you take a little bit of fluid out of a paracentesis, the graft will typically open up. It'll come to that paracentesis. Keep in mind that DMAC graft acts a lot like fluid. It goes where fluid goes. Air bubble, above or below the graft. I rarely do this. A talk I have on tomorrow on sort of extreme DMAC, you'll see me talking about putting air bubbles in when I have a really tight scroll in a deep chamber. These 2 other techniques don't work. You've got to get air to unfold it, but that's more challenging cases. And then direct manipulation of the graft using 1 or 2 cannulas. I'll show you a couple of videos. Again, good for tight scrolls where you physically go inside the eye with a cannula, touching the stromal side of Decimase and get it to unfold. All right, so keep all these in mind. Now the presentation is going to draw a lot from Peter Veldman's diagrams that he has available at patientready.org. And he goes through in that website all the possible configurations of the DMAC graft. The first one here is a double scroll. That's what you want to see. And what he shows here with a cannula is you want to tap along the long axis, creating fluid waves that then push the scrolls open. So that is your preferred technique. I'll try to talk over the band here. That's preferred technique for managing a double scroll. Good thing is surgical videos, you don't really need audio. So, slow injection. It's a double scroll going in already. Okay. So again, you want to make sure you get it out of the clear corneal incision. So just pushing to try to get it out. All right, now you want to just tap. He says tap along the central portion of the graft, but there are other ways of doing it. Watch, what I'm going to do is a press and release maneuver. So here I'm going to tap in the middle. Now I'm going to just tap at the limbus, and as I do that, that side will unfold. This side unfolded already. This is called an edge fold. So that's a press and release. A press and release is a slow downward movement. Can you guys hear me still or no? No? We're gonna, maybe we'll pause a little bit for this band to come by. You typically want to tap along the long axis, as Peter's showing us, creating fluid currents that will unscroll the 2 edges.
Would you try to rotate that away from your opening?
No, once it's totally inside the eye, out of the tunnel, it's not going to come back into the tunnel. You're only really at risk when the graft is still in the tunnel, or if it's inside but you really pressurize the eye a lot, which you're not going to do by just tapping. That's the only time that graft can be expelled through the main incision. So here's double scroll. I want to just show you, again, I'm not doing exactly what Peter did. So here what I'm going to do is I'm going to inject. I've got a double scroll going in. I'm just trying to get it out of the incision. Sometimes it does, the iris comes up, the chamber shallows, and you cannot get it all the way in the angle. Just the way it is, sometimes the iris comes up. You can try to deepen a little bit, but sometimes it will not go that far. So now, Peter would say tap right along the middle of it. But what I'm doing right now is I'm seeing it starting to open for me already, just tapping at the edge. So now it's open enough, I'm going to treat this like 2 edge folds, it's called. We'll talk about that in a second. It's 2 edge folds. So this is a press and release maneuver. I'm going to push down slowly, and I'm going to release quickly. So down slowly, just like this. The quick motion is up, so it creates sort of a vacuum, and that unfolds that edge. So that's what you do when you get an edge fold. So again, there's many ways of skinning the cat.
Are you able to see your denuded cornea under there? It's not, I noticed you don't have a marking.
Can I see where I've done the scoring?
Yeah.
Usually, yes. I usually do have a mark that's still visible. Sometimes it wears off, but I usually can see that, so I know where I've scored. So in this case now, we've got a scroll. So you see the configuration. So he's saying first tap here to try to open it up a bit more, and then treat it like a double scroll, tapping along the long axis of the graft. Now, another configuration is a simple fold. Once you get that fold to open up, you've got one side open one side still folded. So this is where you use this two cannula technique, also known as Durisomer technique. The red cannula is static. It is simply holding the graft in place with light pressure downwards. You can either use the whole end of the cannula or just the tip. You're just trying to pin the graft down here. And then you can use the other cannulas next to it, starting next to it, little chopping movements, like you're chopping celery or cucumbers or whatever. I don't cook. And as you do that, that'll create the fluid waves and get this thing to unfold. Another maneuver would be to hold it down and press slowly and release quickly to create that vacuum. So let me show you how I manage this. All right, so we have right now a scroll, okay? So what I'm going to do is inject some fluid to try to blow this part that's open, to get this part to unfold. Short little burst of fluid. There, I got it to unfold a little bit. How am I get to unfold more? Internal technique. Tapping a little bit of fluid out. All right, and now I'm going to press and release, and there that side unfolds. Now I've got it unfolded like this. Now I've got a scroll, but I've got somewhere I can hang on to. So I'm going to push down. This is my red cannula. Stationary cannula is going to hold that there. And now the second cannula, very light little chopping movements to get this side to unfold. Shallowing the chamber a little bit, because if it's too deep, it scrolls back up again. So little short movements. As you see, if you don't recenter, it's going to get decentered and one unfold. So you have to, while you're doing this, kind of recenter, unfold, recenter, unfold. That's why those two were highlighted when I list the step of the surgery together. It's a process where you're recentering, unfolding together. But that's a technique for taking it from a scroll to a simple fold to unfold. All right, another video, same thing. What do we do when we have a scroll? This is actually a very recent case, just about a week ago. Shallowing the chamber a little bit. Now this is an internal technique. This is direct manipulation of the graft, going in and touching the stromal side, moving it over. I could have done other techniques, but here I wanted to see a variety of techniques, getting it to the same configuration we had on the prior video. Right? We're going to short little press and release to get that side to unfold. I can see by the S is correctly oriented. So now instead of doing the two cannula technique, I'm going to do the press and release. Holding it down there, down quickly, up, down slowly, up quickly, getting that side to unfold. Whenever you have a point like this, where it's like a point, tap at the point. That's a good technique to get it to unfold. Wherever you see an apex of a fold, tap there to get those edges to unfold. All right, now next configuration is an edge fold. We just kind of saw a simple fold goes through an edge fold to unfold. So an edge fold is sort of a small, simple fold. Different ways to approach this. Number one is the same thing we saw earlier. Two cannulas where you can do stationary and just tap it out. Second one is that press and release maneuver. Third technique is just going into the paracentesis, burping fluid out to have that edge unfold. So three different ways to deal with an edge fold. This is, when you get to an edge fold, you're pretty much done. So this video is scroll to simple fold to edge fold. So you get the idea that these configurations, you'll go through these different configurations as the graft is unfolding. So you see almost always I've got two 30-gauge cannulas in my hands working to unfold these grafts. So this is that two cannula technique, kind of tapping it out. Now you note I'm getting a little bit decentered here. So at some point I'm going to need to get this to recenter, and I'm going to push, as I just mentioned, on that apical edge to get this graft to recenter. Often as you do that, it'll start to unfold for you as well. So that technique both centers as well as unfolds. So I'm going to press and release to get that side to unfold, press and release to get this side to unfold. Okay, so now I've got a simple fold here to my left. A lot of different ways to manage this. What I like the best is just this press and release to get that side to unfold. You could have easily done the two cannulas to tap it out.
Where do you do the press and release? At the limbus or?
So usually I'm sitting superiorly, unless I've done cataract surgery at the same time. So I'm sitting superiorly, I'm right-handed, my main incision is at 11 o'clock. My paracenteses are around 1 to 2 o'clock and at 10. So they're about 4 o'clock hours apart. And these incisions for the DMAC are 1 millimeter each, and they're radial. I say that because when I do DSEC, the incision for the AC maintainer is not radial, it's tangential to give me a longer track. But these you want to be radial, you need to be going through them to manipulate the graft.
What do you use for side cord? Just normal side cords, or do you use like MVR?
I use a diamond blade. I use a 1mm diamond blade so that the edges are parallel. Here today we have a 1.1mm blade. It's a little bit different, but I use a diamond for those incisions. All right, now the dreaded configuration, the toughest one to unfold is the taco. Taco, as you see depicted here. Now it never looks like that. If you see a taco that looks like this, where it's 40-60, the top part is not overfolded, that's correctly oriented. If you see a taco that's 60-40, where the top half overlaps the bottom half, it's upside down. Just the way the graft behaves. Very helpful tip to allow you to figure out how this thing is configured, because I've spent many times trying to unfold a graft that's upside down, it's just not behaving before I realize it's upside down. Duh. All right, so here we go. Here is a taco, and how do we get out of the taco? All right, so we're tapping. You guys can see it. You see it's a 40-60. So I know it's correctly configured because the bottom part is open more than the top. I'm pointing this out to the fellow right now. I'm right-handed. I like to be moving things to my right, opening to my right. So I'm going to use two cannulas, always two cannulas, to move it over to my left. If I'm left-handed, it would be the opposite. It'd be a mirror image of this. So these two cannulas are necessary because if you just use one cannula, when you release, it's going to go back to where it was. So the second cannula kind of blocks it from moving backwards. Back in the similar configuration where we've been before, holding it down, press and release. Fairly simple. Okay, so when you have a taco, moving it over to the side will often move it from a taco to a simple fold. You have enough exposed inferior portion of the graft to put your cannula on and then do the two cannulas or the press and release to get it to open. All right, and again, don't worry about people like, God, this is so many different combinations. You'll have this presentation, you'll figure this stuff out on your own, but it is easier, I think, to kind of think about this as far as configurations and techniques to unfold. All right, so here we have a scroll, tapping the too much dye here, so that dye kind of come out, so I have a little too much dye here. All right, now we're getting a taco, almost a simple fold. In this case, you're going to unfold this, but I'm going to want to move it a little bit again to get this thing to unfold more easily for me. So I'm going to align the graft with the mark on my cornea, because that's where I want it to end up. Going to hold it still. I started to do the two cannula technique, and I'm like, screw it, let's just do this. So easy. Again, I'm just using the tip of the cannula here. You know, some other videos is the whole length of the cannula to hold it, but you're probably causing more endothelial damage that way because it's being compressed along the whole length of your cannula. So I think probably better if you want, if you can, just to use the tip. Then these are tapped. This tapping maneuver is like a quick little karate chop. The downward motion is fast. That gets the graft to move away from where you are. Now an internal technique, I drew some fluid out to try to get this side to unfold. So you're seeing a lot of different techniques here. Again, this is the tapping to get it to move away from my cannula, a rapid downward movement. If it's a slow downward and rapid release, it goes towards your cannula. So you can manipulate that graft by touching the limbus depending if it's the downward stroke or the upward stroke is the fast stroke. Does that make sense? Okay. And then bouquet. Common configuration, sort of a friendly configuration, typically when you're doing DMEC surgery. Peter says first thing you should do is tap along the long axis to get this graft to open up a little bit more. Once you have it a little open more, start at the open end and work and be perpendicular, working from here down to here. And I agree with him, get it to open up that way. If you start down here where it's more closed, it's not going to tend to open. But you want it to be open enough to be able to do this. So you'll still have some overlap in your two halves, but if there's just, you want just a little bit of overlap before you go to this portion. Again, I do things different ways, but I want you to see kind of his way, and then you'll see my way here a little different. In this technique, we're going to use an internal technique. Again, you see the second time you're seeing this, touching the stromal side, just moving it over. This is really good for a deeper anterior chamber where you have trouble shallowing it, because when you go in like that, the chamber will not collapse on you. Many chambers, you try to do this internal technique and it'll just collapse. But in a post-vitrectomy eye, high myope, et cetera, you can get away with that all day. I did that last week for a case, really tough case, really deep chamber. Then the same thing you've seen again, press and release. You notice it's always opening to the right for me, being right-handed. just because that way it's comfortable for me. But you can do this in any way, any configuration you want. Fairly easy to get that graft to rotate though. So I'd say when you're starting out, if you're going to do this technique, do it so it's always opening to your right or to your left, depending if you're left or right-handed. You notice here, little tap and raise.
Your incision is scleral, but we do a scleral.
This one was scleral. I don't know why I did scleral here. Sometimes if, this looks like a vascularized thin host, I think it's because the tissue looked bad, so I backed it up into a scleral incision, but usually it's clear corneal. Not uncommonly if you're doing a DMAC, like especially a patient post-PK, the host is thin, is vascularized, you may not want to use that. So that way I'll go back and make an incision through the sclera, but usually it's clear corneal. And then the final configuration is origami, which obviously just means it's sort of a hot mess. So the key here to get this graft to unfold is you're going to deepen the chamber by injecting BSS. Key here is just you get it unfolded, just deepen the chamber. And then the second step then is to just tap on the folded edge. I was talking earlier about tapping on the apex when you have a graft to get to unfold. Same thing here, you're sort of tapping where it's folded to get this to then assume a scroll. Then you can work from there. So let me show you a case of mine. This is a case from 2 weeks ago, pressure of 2 pre-op, failed DSEC from 12 years ago. I've got a bit of an origami here, so I'm deepening the chamber, step number 1, and then I'm pressing right at the apex of the fold. You can either just tap directly on it or the length of your cannula to once it gets into that scroll configuration, now you can start again. This is a tough case. This is a case where you had to put air behind the iris to bring the iris up to have the eye shallow enough to actually be able to do the DMAC. Really challenging case. I'll show that video at our course on tomorrow. So, I want to make you guys feel a little bit better, maybe make you feel worse, I'm not sure which this will do. This is Rex Hamilton, who was a colleague of mine at Stein for many years. He's now in private practice. And this is his son, Will, who is in 11th grade with my son at Geffen, which is UCLA's primary school. I want to show you something here. He's into Rubik's Cubes. And so this is Will at a recent Rubik's Cube competition, taking a look at the cube. Smart kid. He's like, okay, I can do this. Notice one hand, and he's about, I think at this time he was 15 years old, and he solved that in 13 seconds, okay? So let's review here for a moment. DMAC, number of possible configurations, around 7 I just presented to you. Rubik's Cube, 43 quintillion configurations. How many hands can we use when we do DMAC? We use both our hands. What if you're doing this Rubik's Cube competition? Only one hand. And how long does it take to unfold a DMAC graft? Well, usually a few minutes. It's pretty good. This competition, you better be under 15 seconds, you're not going to place. So, some people have it tougher. This is not that hard. It is not doing one-hand Rubik's Cube solving in under 15 seconds. We can all do this. So if you're interested in getting a copy of this presentation, take a picture of that QR code, and it's uploaded along with other talks on DMAC, including the presentation for course tomorrow on complicated DMAC. Does anybody have any questions for me?
Do you use gas or air?
So the question was, do I use gas or air? I use just air. I have not used gas because I have not, fortunately, had a very high detachment rate. It's pretty rare that I go back to rebubble. I'd say if you're doing DMAC and you find that you're having to rebubble more cases than you like, then I think you should think about going to gas. But if you're having good success, low detachment with air, I think there's no reason to change.
What is your air fill at the end?
Yeah, so it's a 10-minute firm air fill. I like it like this countertop, if possible.
10 minutes.
Then, for 10 minutes. Then I take out enough air such that the air bubble does not cover the inferior PI. And I make an inferior PI with a YAG laser prior to surgery. So it's about maybe an 8mm diameter. The DMAC, my default DMAC graft diameter is around 7.75. For a Fuchs patient, it can be a little bit smaller because your peripheral endothelium is functioning. If it's a pseudophakic corneal edema where there's no endothelial cells that are functioning, maybe go up to 8.25. But it depends. If they've had a prior DSEC and you strip that out, you'll often have this sort of fibrotic ring around where the DSEC graft was. You want your DMAC to be within that. And so I'll go maybe a 1/2 millimeter smaller, or 1/4 millimeter smaller than whatever that prior DSAC diameter was.
What's your post-op regimen?
So post-op regimen after DMAC is the same as after DSAC. So it's fluoroquinolone, QID, for 10 days or until the surface heals, whichever is longer, until the film closes. And then a topical steroid, usually prednisolone acetate, QID for a month, TID for a month, BID for a month, then QD thereafter. If they are phakic, which is rare, if they have an issue with pressure rise, then I'll switch over to loteprednol etabinate after about 4 to 6 months. I typically keep them on a steroid though for life, because we know from Frank Price's study, stopping it increases the risk of rejection up to around 6% from a baseline around 1%.
For positioning?
Positioning, so at the end of the surgery, they go to the post-op area, they're on their back, and they're going to be there until I do another case and come back and look at them. So maybe an hour or two later. I have them sit up, take a look with a portable slit lamp, make sure the bubble is above the PI, make sure that the graft is attached. You should have a bubble almost filling the anterior chamber, so the graft's going to be attached because there's air behind it. So that's really not a concern in a DMAC. Then I have them lay flat the day of the surgery. Go home or wherever they're going, the hotel, lay flat, come back and see me the next day. Then usually post-op day 1, I say be flat half of the day. They don't have to be flat all day, about half the day. Then I see them back usually at 1 week. At that point, all the air is gone. I have them sleep on their back for about 3 nights after surgery. I figure after that time, the amount of air that's left is minimal. There's no need to have them positioned anymore. All right, so I think now we'll get to the fun part. That was the fun part. Get to the other half of the fun part, doing the demonstration here. And we'll take that out.
Rate of rebubbling.
Rate of rebubbling is probably 5, maybe 5%. Something like that.
OCT?
I do, if I think that there's a detachment, if I know there's a detachment, I will do anterior segment OCT to try to quantify it and use that together with my drawings and description and text in the note to know whether that detachement's enlarging or not. And that's often what kind of triggers me to think about should I do a rebubbling. So I do use OCT post-op to identify detachments and quantify detachments. Put this up here.
So efficient. Thanks for sharing that.
Sure. Oh yeah.
Oh, thank you.
I used to put in like the Dropbox link. It's like 50 letters long and numbers. It's like, this is crazy. QR's a lot quicker.
Yeah, very nice. And so you have a little
Hemostat,
here.
good.
Yeah, right. So that was like otherwise.
All right. I don't know how to sit. I got drawers in my knees. I'm trying to figure out how to best get in here. Gonna move this back over. All right, so you guys can see our anterior chamber here. So we're going to make those incisions we talked about. Usually going to make your paras first, so you can find them. I like to ink this. We can just watch. I think, well, that's okay. When you're moving, this scope's moving a little bit. No problem. Whoop, it's moving a lot.
It may be
You can
me.
just, yeah, okay.
Might be.
You guys trying to sabotage me.
You make it look too easy.
Oh, hardly. Just you wait. Looks like this is not inking well. Do we have another marker?
So you have to dig in the drawer a little bit to see if I can pull another one.
You said that you are sitting superior. Why superior not? Because most people they sit temporal.
Because I'm tall. And our beds, when I'm sitting temporal, like for cataract surgery, I'm having the same problem I'm having right now. My damn leg's just too long. So that's why. That's why. No good reason. A little ink on that one. So you blame my parents. Blame my dad. And, okay. Ideally, it's about a 1 millimeter incision, these paras. The 23 gauge EC maintainer you saw, actually I take that back, that one goes through about a 0.8. If it's a full 1 millimeter, seems like not a big deal, it can leak a little bit. So the one the AC maintainer goes through is usually 0.8 millimeters. All right, now we have this AC maintainer full of air. We do that because we want this has a latex glove, portion of a glove here serving as the iris. If that's up, I can stab it when I make these incisions and I got a problem. So now we're going to take the air out with our BSS. Make sure we have BSS here. So needless to say, you want no air in the eye when you're inserting the DMAC graft. Okay. And do you have some BSS to squirt for me?
I should do.
Okay. All right. So you guys can see 2 of my incisions. Okay, so now you're prepped. And if you guys don't know if you really want to practice, but this is from Catena. This base is very helpful. It weighs it down, otherwise it kind of moves around. So I do a lot of DMAC training. I was just in Armenia 6 weeks ago teaching DMAC, and we have the same setup there. So now our graft. It comes in here we go. Comes in this viewing, well, this is the viewing chamber. It comes in a vial like corneas kind of often used to come in. So all you really need on your back table is, I'll just tell you, your setup is going to be a 5cc syringe with BSS but no cannula. I like to have a 3cc syringe with BSS. And this is really if the graft's coming out the back to kind of coax it back in. And then the hemostat you're going to use to pull the graft, the cannula and the carrier out. So then, thank you much. Has a little bit of a bend, so you kind of bend your hand like that to get it out. Okay, so everybody can see what it looks like here. You notice that actually these guys are trying to do it to me. They've got a little bit of an air bubble. You got light reflex, so I'll see if I can focus for you. This foot pedal is configured differently than the one I use in the OR, so you get to bear with me as I try to figure out how to zoom and focus. It looks like it's not doing either.
So the height difference, we may have to just manually move down
Yeah.
the scope.
Okay, you guys can see that? Okay. So, very easy to just lift upwards and out of this carrier. When you do it, probably wise to hold on to the wider portion of the cannula. This portion is delicate, the neck of the cannula, so you really don't want to be manipulating it. Also, when you take this cap off, this neck is not round. It's sort of like flattened circle. So if you twist this as you come off, you can actually break the tip of the cannula. So just be careful that you pull it straight out. Don't get cute. All right, so right now our graft is positioned well. You see it's in the middle of the cannula. It's often back here though. It's often back here, so if I take this part off, I worry about the graft coming out. So I'll show you what I do often is just tap like this. And as you tap, the graft will kind of sink down. It'll go away from the opened end, which is what you want. In this case, it's well positioned. Doing that though, as you see, gives you an air bubble. So that's what I have this other cannula for. So I take off this back portion, and now I'm going to, this has air in it though. And I'm going to take that bubble out. It's easy to do. All right. There you go. So easy. All right, once that's out, now you're going to take your 5cc syringe. You want to push so you kind of have some fluid at the very tip, so you're not introducing a bubble between it. Oh, this is sticky. This could be a fun insertion. You really want non-sticky cannulas or syringes. I think BD, I have no financial interest, makes the best syringes. It matters. I've done this in Vietnam, I've done this in Armenia, I've done this in Jakarta, where I had sticky plungers. Everybody's grafts went flying at these high rates of speed. So now I always bring my own syringes. So BD is the best. All right, so connect it, very easy. Now, as I mentioned, you're just going to pull straight off with this tip. Don't twist it, just pull straight off. Sometimes it can be a little snug, that was fine. And now we're going to, can you guys see? The light reflects from the water sometimes make it a little tougher to see. We're going to exchange the BSS, I'll do it this way, for the Optisol. So I'm just very slowly pushing on my plunger. Problem is we got a sticky plunger here. So sticky I'm actually going to switch plunger. This one's dangerous.
You got another one to do?
That one is dangerous. Do you have another? We have this one. Can you take this cannula off for me? 3 is probably enough. I like 5 just in case you get a chamber that keeps shallowing, you need all the BSS you can get. I like to have a 5 as backup, but rarely do I actually need that much fluid. And we got a big bubble there. Okay, so we're going to take, does that have BSS on it? There we go. Okay, again, make sure you have just fluid. Okay, and our graph's already ready to go. So I'm going to pull back on it a little bit. Now, can you guys see very well? Another light reflex on the water makes it tough, but can you see the graph? Okay, if I put my fingers either side, it helps it a little bit. So, okay, so now you can see I've got a simple scroll. And it looks to me that it's going to be correctly configured if it goes in like this. So I think we're in good shape. So I usually advance the graft so that it's in the skinny part, doesn't have to be all the way down. And this plunger is a little sticky, so I don't want to push it out. So I'm just going to leave it right there. In this case, now we're ready to go. So you want the graft in the thin portion of the cannula before you inject. Bring this back. And now we're going to come up. Let me just put that down so I can adjust the microscope a little better. Do we have a dry 4x4? My gloves are pretty slippery, thank you. Alrighty. How firm should the eye be when you insert? I think it should be normal tension, normal chamber depth. Some fluid's going to come out in advance of your graft, obviously going to pressurize it, make it a little deeper. You don't want a really firm eye to start with because the graft dust is not going to go in. Again, the graft acts like fluid. You don't want a super soft eye because it's hard to get into. So you want something that's a normal pressure. I'm also going to have ready a pair of .12s to tap from this para if I need to try to soften the eye. Hold it like a pencil. I think it's easiest, hold like this, and then with your left hand, you're holding on the eye with your .12s when you're putting this in. Then I use my left hand to slowly push on the plunger. Again, it's usually little short bursts. I have a feeling this is going to go flying in at a pretty good rate of speed, so this could be exciting. Hang on to your hats. Hang on to your hats here. All right. Let's see if I can focus up. Okay, so I'm in. Can you guys see the tip of the cannula? Okay, so it's just inside the incision. I'm trying to focus up here. Okay, and now little short bursts of fluid. Good, so that's in. Okay, now we can tap. That's going to stay put just nicely. There we go. Okay, now again, if you really want to do everything perfectly, if you tap that paracentesis, sometimes it does create the graft's rotational force and it does kind of rotate. That's the safest. Not a bad idea when you're starting, because you don't really have a sense as far as how firm is this eye, what's the likelihood it's going to come out. To be safe when you're starting DMAC, try to see if you can get it to rotate a little bit, because then it's really not going to come out and do anything silly. Okay, now your job is to make sure that this chamber is a normal depth. Right now it's a little deep. You're not going to get a graft unfold if it's too deep. So now you want to shallow the chamber. And you're going to do that either going through one of your paras or your main incision. And I'm trying to get my focus to work here. Let's see, is there a manual focus? That's right, I can kind of guess. So I'm going to just tap a little bit here. Okay, there we go. Going to tap some more. So I'm just trying to shallow this eye a little bit. In these eyes here, if you do a wet lab, you can actually bring the iris diaphragm up a little bit. So in other words, you can push a little bit of fluid from behind the iris. And in real life, you really can't do this. It will help to shallow the chamber a little bit. So this is what I'm doing. I'm just pushing a little bit. Looks like it's not shallowing for me. That's unclamped. Okay, I don't know why it didn't shallow for me. And a little BSS. You know, you can see that this is a deeper cornea, a deeper chamber, because I've got, the cornea is right now is concave and the graft is still scrolled. So we're going to need to bring this iris diaphragm up. So let's see, this is air behind it or fluid? Air, okay. Trying to do this without pushing too hard too quickly. It's stuck. I think what happened is this had air in it so long that the latex has stuck to the plastic. You know what I'm saying? I think that air bubble in there so long caused the latex stick to the plastic and it's not reforming.
Try the other two.
Let's try the other one, yeah. This fortunately is an artifact of the wet lab setting that's not going to be an issue in real life. So that's a good thing. Yeah, it just the latex is stuck to the plastic because it was in there too long. It's flat too long. Let me see if I can break it. Now this may cause a sudden expulsion of the graft, just so you guys get your money's worth here. Nothing, it's stuck. We may have to disassemble this thing. Let's see. Let's try fluid. Go with this one. Nope. Not happening. All right, well, maybe I can tell you what I would do if we could get a chamber different. This is just, it's too deep. It's too deep. All right, so in a case like this, you do try to shallow it as much as you can, but here it is really deep. Deepen it to shallow it. You guys can see by the light reflex now, this cornea is concave. You can see that sometimes that's what you have to do in these post-vitrectomy eyes. And then we have, what configuration do we have here? It's a scroll, right? It's a double scroll with a little bit of overlap. It's almost a single scroll. So what we're going to do is tap on the long axis. Okay, now we've got what configuration? That's a simple fold. We have one side unfolded here. We can get that guy to completely unfold, a little BSS if you would on the cornea. And then we've got this here. So when we have this configuration, we saw several videos showing what to do here. Again, this continues to scroll upwards because the chamber is too deep. See if I can shallow it even more. There we go, see how that unfolds there. And so now we can either do two cannula technique, one pinning down the part that's open, the other one tapping, or we can do the press and release. When you have a very concave cornea like we have here right now, because our iris is stuck all the way down, may or may not work, but let's give it a go. Well, how are we doing on time, by the way? It's almost, just want to make sure I don't overstay my welcome.
You're perfectly fine. You're the last presentation.
Okay. All right, so let's see if we can do this. So I'm going to pin this one down. Here we go. There we go, voila. Works even in an ultra deep chamber. 12 seconds. There we go. All right. So that really does work every time. Make it comfortable for you though. If you move the graft around, it is uncomfortable for me, even done this hundreds of times, when I'm unfolding to my left or toward me. So really rotate it to where you're most comfortable. The only time you'd alter that is if there's a tube, and don't be doing this early in your career. If there's a tube, there's peripheral anterior synechia, something like that may make it harder to unfold, then you may have to unfold it in a different direction. But do what's familiar and comfortable to you, and you're going to do that better. And also builds your muscle memory quicker. Now, the last step is to make sure you don't seize defeat from the jaws of victory. I have seen this too many times in my hands and other hands, which when you put the air bubble in, if you're too hasty, you just go in and put it in. Sometimes the air bubble comes out too fast, it pushes the graft to the side, it scrolls up, and you get to start all over again. So you have to be very deliberate when you go in the air bubble, go right underneath the middle of the graft, use a 1 cc syringe with only 0.1 cc of air, and inject very slowly. That way the graft will not move, it'll come straight up. So let's do that. We have, this is okay. So this is our 1 cc. I usually use a slip tip cannula. I don't know if a syringe, I don't know if it makes a difference. This is a lure lock. I just found that when I've used the lure lock, sometimes air comes out too early. So I'm very particular about all these things. I don't know if it really matters, but that's what I do. All right, so now we're going to go in. You can go in through your main incision. You can go in through a paracentesis, however you want. We have a lot of fluid here. Let's see. And so those bubbles are coming out before I'm not even touching the plunger yet. Trying to get underneath this guy. There we go, and then inject. All right, now this is actually good that we've got these folds. You see these folds? There's a fold here and a fold here. It's actually a good learning point or teaching point. When you have those folds, they're easy to unfold, but they won't unfold if you have air beneath it. So you've got to have only BSS below a fold to get it to unfold. So what I'm going to do is inject a little bit more BSS. Should shrink my bubble a little bit. There we go. You can also, in a real life patient, kind of tip the eye a little bit. So tip it away from the fold, the air goes that way, and then you just tap it out. So I'm going to do this. Can you, there we go, see that? Unfolded. Okay. So it's not hard. That bubble is probably a little bit bigger. Here we have a fold. If I go through here, that should unfold it for me. There we go. Okay. And now you've got almost complete airfill. Now you go in for the kill. Coming in here. Is that Shannon Wong, by the way?
Yes, Shannon.
How are you? Do you remember me? Good to see you. Your father was my mother's ophthalmologist in Austin, from St. Stephen's also, right? Good to see you.
Good to see you.
Yeah. All right. From back in the day. All right. And then, can you irrigate? I like to get a firm fill. I like to hydrate a para like this. It's like hydrating a para. So go with like this to get your firm air fill. Okay. And then you just wait 10 minutes. And then we talked about leaving then enough air such that it doesn't cover the inferior PI. So firm fill, 10 minutes, taking out the air. The air bubble will be around 8 millimeters or so, or maybe even up to 10, depending on where your PI is, and then send them back to recovery. So that's it. I mean, this graft behaved. This was a nice graft in that it kind of wanted to open up for me. Ultra deep chamber, thank you guys for that. But even with an ultra deep chamber, if you have a graft that wants to open, you can deal with it by just making that cornea concave. The kiss of death is the tight scroll and a deep chamber. In that case, your tricks are really, as I mentioned earlier, putting air behind the iris. How do you do that? 1 cc syringe, 0.1 cc of air going out underneath the pupil, going way out in the angle, put in 3 air bubbles. That brings the whole iris up, helps immensely. The other thing is if you have a tight scroll and it still won't open the situation, putting an air bubble in the scroll will help kind of get that graft unscrolled. Then you have to put air in to get it to unfold. That's the only time I ever use air in the anterior chamber to get a graft to unfold. So any questions about the videos or the unfolding here, the demonstration? Okay, thank you very much for your attention, appreciate it.